Good evening, participants. Thank you for joining Shield Connect. Today, we have a series Icons in Conversation with Dr. Ritu Sanfani. And today, the topic is pre-treatment evolution of fibroid uterus. And speaker for the day, we have a well-known doctor from England, Dr. Deep Datta. And so let's go with our speaker's detail. Let me introduce, first of all, Dr. Ritu. So Dr. Ritu Sanfani, ma'am, has a good experience in IVF in Pune Test Tube Baby Center, and ma'am is also a consultant of Shamwell Women Clinic, and ma'am is a honorary professor of obstetric gynec in WIMS Medical College in Gajrula. And let me give a brief intro of our speaker, icon speaker for the day, Dr. Deep Datta. Sir has a MBBS MD from FRCOG UK, and sir has also done FRCP from Ireland. Dr. Datta is currently a consultant in as an obstetrician and gynecologist at the Maidstone and Tunbridge Wells NIH Trust in England, having been a past council member and a member of the board of trustees at the Royal College of Obstetricians and Gynecologists. He has undertaken pioneering work in obstetric and gynec simulation and enhanced recovery post-surgery in United Kingdom. Besides having participated in several research projects over the time. So we welcome you, sir, on our platform, and I will hand over the session to Dr. Ritu.
Thank you, Dr. Nishan. A very, very warm welcome. Our today's icon, Dr. Datta sir. Sir, a very, very warm welcome. Welcome to all our delegates who have joined all across the geography. I am able to see some of my friends have joined from Africa, and Dr. Kariman has joined all the way from the Lebanon, my dear friend. So I think all of you agree with me that knowledge is the power, and knowledge always increases by sharing. With this motto, I started this series. On every Thursday, actually, we are inviting 8 p.m. Indian Standard Time, one icon, and we are going to discuss regarding the one topic. Post the presentation of the speaker, today, Dr. Datta is going to share with us what the pre-treatment evaluation for the fibroid uterus. We all are getting a lot of fibroid patients in our OPD. So there are a lot of queries in everybody's mind. So this topic is very, very important. First, sir will take the presentation, and after that, all of you can ask whatever the questions you are having related to this. Besides this, the program is going live on the YouTube. I am already posted the link. Again, I will post the link in the chat box. A very, very warm welcome, sir. The dais is all yours.
Thank you so much, Ritu. I'm just going to share my presentation. Thanks for the introduction. It was very kind of you. And I'm very glad to be with you today to speak on, like Dr. Sanfani said, a very relevant topic. So, and across the spectrum, across the world, it's the one problem that we face a lot of times, from menstrual problems to infertility and so on. So what I'm going to do is, because there's so much being discussed and taught about the surgical evaluation or surgical treatments of fibroids, I'm going to stop one step short of that and explore how we build the workup to the diagnosis of fibroid before proceeding to surgical treatment. So I will touch on medical treatment as well. So it is obviously the most common tumor in the human body. It is all known as myoma, leiomyoma, or myomas, and is derived from a smooth muscle cell rest from the vessel wall or the uterine musculature. So you've got blood vessels in the uterine muscle wall, and the cell rests from these vessels or the uterine musculature itself gives rise to balls of the fibroid tissue mass. So 77% of hysterectomy specimen, you will see some of the evidence of fibroid uterus development. It's very high in Afro-Caribbean compared to white women. I've not purposely quoted the incidence in Indian population because obviously the incidence varies from across state to state and from region within the state also. So there's a wide variation from Kashmir to Kanyakumari. But as you can see in Afro-Caribbean women, over 50 years, 80% of women will have fibroid uterus in some form, compared to 70% in white women. And most of them are obviously asymptomatic, so they don't seem to disrupt their lifestyle. So let's talk about the etiology. Genetic is 40%, which is important to remember when counseling patients. There are hormonal and growth factors. So the genetics is usually translocations on the 12th and the 14th chromosome and deletion of the 7th chromosome and 12th chromosome, although leiomyosarcomas have a different origin. So we understand that, although leiomyosarcoma in clinical experience are not very common. So hormones have a role to play, and there's an increase in the receptor numbers and responsiveness of both estrogen and progesterone receptors. And you have hyperestrogenic states like obesity, carcinoma of the endometrium, early menarche, or anovulatory. In short, any state that actually produces high levels of estrogen increases the mitotic counts in the uterine vessel wall musculature and also the uterine musculature. And you find it that there are less fibroid after menopause and before puberty for obvious reasons, because these are hypoestrogenic states. And so the fibroid incidence is much, much less. So some growth factors have been involved with the production of fibroid. The most important of this is the TGF, or tumor growth factor beta, but there are other factors, and those who are involved in work with cell biology and molecular biology and genetics are probably more interested in these growth factors than us clinicians, who this talk is mostly directed to. So there's a role of growth factors or hormones interplay, and as you can see, the estrogen and progesterone productions from the ovary directly contribute to the tumor growth or proliferation, and the autocrine factors like tumor growth factor beta can also help in the development of leiomyomas. So the risk factors, what increases the risk of the development of fibroids? As you can see on the left-hand side, you've got age, endogenous hormone, which means the earlier the menopause, earlier the menarche, the higher the risk. Family history, like we said, 2.5 times or 40% influence. Afro-Caribbean, and weight, which means higher BMI, is directly proportional to that. So there is a decrease as expected with healthy food like green vegetables, exercise, increased parity obviously, and smoking curiously decreases the risk of fibroids. Not that that is a reason why one should smoke, of course. And then these are the ones that have no effect on the development of fibroids, namely the OCP or IUCD, so two main forms of contraception, besides some of the infections like STI, cytomegalovirus, and HSV infections. So this is a pictograph you can use in your clinic waiting rooms or your patient information leaflets: genetic factors, extra weight, the race, vitamin D deficiency, birth control, early onset of periods, alcohol, and a diet low in fruits and vegetables that can stimulate the growth of fibroids. There are some things you can't influence, like the race, obviously, or the early onset of periods, but you can definitely, or genetic factors. But what you can influence is extra weight, alcohol, and modified diet and exposure to sun. So there's some modifiable factors, obviously. So site classification, so uterine fibroids are in the body, either in the subserous area, about 15%, interstitial, that's mostly in the muscle, which could be the subserous or broad ligament or parasitic or floating around in the pelvic cavity. Submucous, about 10%, you can have sessile or pedunculated. Sessile has a stalk, of course, and pedunculated a longer stalk. In the cervix, you can have fibroids which are in position at the front or central or to the side. There are other kinds of fibroids which are intravenous leiomyomatosis and peritonealis disseminata, which means they're disseminated throughout the peritoneum, and we could also call it parasitic. And there are basal leiomyocytes in extragenital tissues. very rarely reported and written up. Okay, so the FIGO classification is the palm and the coin. So if you look at the palm, so the polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia algorithm. So if you look at that, then the leiomyoma is then classed into submucous and other. And if you look at the table directly down, that's how the FIGO classifies it, going from within the uterine cavity to outside. So within the uterine cavity, a 0, as you can see in the picture there, that is totally pedunculated. And then number 1 is mostly in the submucous cavity. So that's more than 50% is in the submucous cavity and less than 50% in the intramural. And 2 would be, again, the reverse, which is most of it is in the muscle of the uterus, very little in the lining of the uterus. And these are the 3 fibroid types that can be resected transcervically. So you can resect 1, 0 almost completely, and 2 all partially, but you cannot resect 3, which is largely intramural, only a little bit in contact with the endometrium, and then 4 is almost wholly intramural. And then as you move outwards, 5 is actually subserous, but most of it is intramural, more than 50%. 6, most of it is extramural, that is, less of it is in the muscle of the uterus, and 7 is totally outside the uterus itself, which is subserous pedunculated. So that's the submucous to other classification from the FIGO, the palm. And the hybrid, obviously, like 2-5 would be submucous and subserous, each with half or more than half within the uterine cavity or outside. Now, what is coin? Coin is actually the classification based on etiology. So coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, not otherwise classified. So we tend not to use this one. We tend to use more this one in terms of a location. And the reason this classification is used from FIGO is because it helps you try and underline the treatment pathway that you're going to chalk out for the patient and explain this with her and her relatives. Okay, so what are the symptoms? Bleeding first, you could have asymptomatic 50%, but abnormal uterine bleeding, which is 30%, could be as menorrhagia, mostly intramural and submucous, metorrhagia, submucous and endocervical cancer, polymenorrhea, prevalent discharge. Sometimes discharge from an infected cervical or endometrial fibroid polyp can be your first sign that a woman has a fibroid uterus, and then you might be able to explore that. So continuing on pain, you could have spasmodic dysmenorrhea, a congestive one. You could have pain from torsion, hemorrhage, or red degeneration. Red degeneration, again, you particularly find during pregnancy. So women with known fibroids or fibroids detected in pregnancy will have red degeneration and consequent pain. Chronic pelvic pain, depending on sites, mostly posterior low-lying fibroids, can cause chronic pelvic pain by pressing on sacral nerves, and rapidly growing sarcomas obviously are a nuisance as well with regards to pain. So apart from bleeding and pain, what else can the woman present with? Pressure, of course. So you've got retention of urine in premenstrual women, and some fibroids can cause acute retention of urine. You've got retention in the urinary tract, causing hydroureter hydronephrosis, constipation by actually pressing on the large bowel, and intestinal obstruction by pressing on the smaller bowel loops of the ileum and jejunum. So apart from bleeding, pain, and pressure, what else can you have as symptoms? Subfertility, of course. So distortion of the cavity, PID and endometriosis, anovulation in terms of coexisting of these. And the fertility rate depends on what kind of fibroid you've got. For example, submucous fibroid, it decreases fertility, definitely. Subserosal, there's no effect, and intramural, there's slight decrease. But again, there is variation between different study groups and depends on which literature and which paper you read. So what are the symptoms? Miscellaneous ones. So apart from bleeding, pain, pressure symptoms, and infertility, miscellaneous symptoms are rapid growth of a lump, a pseudo-Meigs syndrome, which we don't see very often nowadays, and secondary to anemia and vaginal discharge. So some women, especially in the rural setting, might give the first clue of fibroids because they are having heavy menstrual bleeding, almost certainly due to fibroid uterus, and then they get diagnosed because of detection of anemia or vaginal discharge or both. Okay, so this is a health and education pictograph to actually tell your patients in your outpatients or in your leaflets, educating them about symptoms of fibroids can give you, like heavy monthly periods, pelvic pain and pressure, constipation, bloating, anemia, pain during sexual intercourse, depending on the size and location of the fibroid, of course, frequent need to urinate, and these are especially on the anterior wall of the uterus, and pressing on the bladder, and infertility. So all of these can actually be symptoms that can alert you or the patients to fibroid uterus. So diagnosis is based on history and risk factors. So you take a genetic history, a family history, a history of bleeding, pain, pressure, infertility, miscellaneous symptoms, and then you have an abdominopelvic examination like we're taught in medical school. So irregular uterine enlargement, firm, non-tender, mobile, arising out of the pelvis, and this is a classical examination description of fibroid uterus. And then you have imaging and endoscopy procedures. So I'm going to spend some time with imaging and endoscopy procedures once you've done the clinical examination to actually help us build up the pre-treatment profile of the fibroid uterus management. So what are the treatment or the imaging modalities? So first one is ultrasonography, and that's a preferred one. It's the cheapest, it's the preferred one. Calcified fibroids are better seen on conventional x-rays. We don't do them generally, and sometimes you can stumble upon fibroids, calcified fibroids, incidentally, if you are doing x-rays for some other reason, or they have been x-rayed in some other department like orthopedics or something. Sometimes MRI will give you additional information where the picture is confusing, and I'm going to come to that in a minute. Diffusion weighted imaging also helps, especially if you're considering uterine artery embolization. And finally, the CT scan is limited. Apart from fibroid calcification, may be more visible on CT than on conventional radiographs. But the role is limited in detection of uterine fibroids. So let's talk about ultrasonography first. So it's the imaging modality of choice, and the sagittal sonogram here shows a posterior fundal fibroid, as you can see, 4.2 by 3.5 centimeters. It's an intramural fibroid, and that's very clear. Again, a subserosal fibroid, you can see there the subserosal fibroid, 2.3 to 2.5 centimeters, right anterior fundal uterine fibroid. And how do they appear? They appear as concentric, solid, hypoechoic masses. We're coming to that in a minute. They might not all be hypoechoic. Some will be hyperechoic. Some will be anechoic, of course. And this depends on how much of cellular activity has gone on, how much of cellular necrosis has happened, and because these cell masses will absorb sound waves and hence cause a variable amount of acoustic shadowing. So that's why it's not uniform in all patients, and that's why you have to have a high index of suspicion when you're scanning these women. So fibroids vary in the degree of echogenicity. They can be heterogeneous or hyperechoic, depending on the amount of the tissue present, or depending on the amount of mitosis that's going on at the cell level. And some fibroids can be anechoic or no sound waves being reflected at all, and that is from necrosis. But then there are some fibroids that are isoechoic, which means it's almost homogeneous with the surrounding uterine musculature tissue. The only ultrasound sonographic sign may be a bulge in the uterine contour, or also maybe a depression of the endometrial cavity. So if you see a change in the endometrial cavity, but you cannot see a hyperechoic or a hypoechoic mass adjoining the endometrial cavity, you suspect it is likely to be a fibroid. And then fibroids in the lower uterine segment can obstruct the uterine canal and cause hematometra, for example, or pyometra. And that could be a clue, although the fibroid may not just stand out as a hyperechoic or a hypoechoic lesion on ultrasonography. So, of course, there are limitations of ultrasonography. It is the modality of imaging of choice, but you have to realize that sometimes you have to depend on ancillary signs like change in uterine cavity, the endometrial cavity, or blockage of the cervical canal, and so on. So the echogenic endometrial stipe is deflated. I've told you that before. Calcifications are hyperechoic, we know that, and diffuse leiomatosis. So this is something that is strange. So if the fibroid tissue is heterogeneous and spread throughout the myometrial space, then you have just an enlarged uterus with abnormal echogenicity, and maybe ultrasound is probably a limited benefit or limited tool in trying to diagnose that, but it gives you some pointer or indicator that that could be the problem. So vascular density, ischemic necrosis, and histological cellular activity. So I think all of these, the histologic cellular activity has a direct proportion of statistical scoring with 3D power Doppler ultrasound indices. And then if you compare that or correlate such kind of pre-treatment evaluation and then compare it with post-treatment or post-surgical removal of fibroids staining, like in Ki67 staining or positive CD31 staining, you'll find that there is a high correlation with high 3D power Doppler 6. So that is something that scientists have looked at of pre-surgical evaluation on ultrasound and staining by chemicals outside the body, like in the removal of the specimen. But in contrast, ischemic necrosis, so where you have got less dense tissue, for example, and less histologic cellular activity, for example, it is statistically related to a low 3D power Doppler 6. So I think it's good to know that there is close working between histopathologists, between clinicians, and between our imaging colleagues, so people in radiology and ultrasound, to try and get to, especially if you're doing a research and workup on writing up of how these are interlinked, and this interlink is demonstrated. So again, this is a subserosal fibroid, as you can see in the right anterior fundal area. So what's the degree of confidence? So the ultrasound has a sensitivity of 60%, a specificity of 99%, and accuracy of 87%. If you just remember the figures, and we'll come back to these figures in a moment. But again, like I was saying earlier, you have false positives and negatives, and about 5% of patients you'll have a false positive or false negative result. For example, necrotic fibroids may mimic normal pelvic structures, for example, even the ovaries, or pathologic variants like uterine variant, pathologic condition like uterine variants and pregnancy-related conditions. So then what do? You move on to the next mode of imaging, that is MRI. So if you've got a confusing pelvic ultrasonographic findings, for example, your clinical profile, your history, your patient symptom profile, your clinical findings are suggesting it's a fibroid or a bulky uterus, but your ultrasound is not very conclusive, you move on to the MRI. And that is because fibroids masquerade as pelvic structures like the ovaries, or uterine variants like a didelphys uterus or a biconate uterus, and pregnancy-related conditions like a molar pregnancy, perhaps, of atypical ultrasound appearances. So where does magnetic resonance image? So that is the background where you'd use an MRI. Okay, so it's an important role in defining uterine ovarian anatomy, where ultrasound findings are confusing. So you're not quite sure. Your clinical profile is actually suggesting it could be fibroids, but your ultrasound is not very certain. That's where you'd use MRI. And you can see how the T2 weighted MRI shows an enlarged uterus with multiple fibroids here. And then the next picture also shows you something similar. And basically the reason the MRI is useful, because for selective surgical removal of fibroid, for example, in a woman who's trying to conceive, the MRI is helpful in planning myomectomy, or the extent of dissection that you'd want to do during surgery. And that is why the MRI might be useful where you're trying to conserve fertility and fertility-sparing procedures, like even uterine artery embolization. Okay, so 1/3 of fibroids have a hyperintense rim. You can see that here, the hyperintense rim. It's a partially hyperintense, and it's a smaller discrete fibroid is depicted in the fundus, and that is the, where's my marker? There's a smaller fibroid discrete in the fundus, but that is the hyperintense edge that you will have on T2 weighted imaging with the MRI, and you might not see that on ultrasound as clearly. So a high signal density, you'll have an inhomogeneous area, and sometimes you might wonder why that is from. It's because of hemorrhage or hyaline degeneration, edema, or highly cellular fibroids. So you can have highly cellular fibroids, which means high mitotic activity going on. You could see, again, you could have less mitotic activity, for example, from hyaline degeneration or hemorrhage. And so less stiff fibroids appear lighter, but stiffer fibroids are darker on T2 weighted imaging. And this is an example. So the third mode of imaging is not very popular. I'm just mentioning it because some of you might come into contact with it, and you must know about this. And this is gadolinium-based contrast. It's not usually required, but if administered, it will enhance the fibroids will enhance later than the healthy myometrium. So the healthy myometrium will enhance first, and the fibroids will enhance later. And most fibroids are hypointense, similar to hypoechoic areas seen on ultrasound. Some are isointense or hyperintense, correlating to hyperechoic or isoechoic fibroids on ultrasound in relation to that of the surrounding myometrial tissue. So what's the problem with gadolinium? And this is why we should know about it. It is linked to the development of nephrogenic systemic fibrosis or nephrogenic fibrosing dermopathy. And both are not good conditions, of course, because they can occur in patients with moderate to end renal stage disease. So you should do, before you use any contrast-based agents, you should actually have an estimate of the renal function of the patient, or at least two occasions. That's what I say. Sometimes you can have a false negative panel of blood tests that suggests that the urine function or the urine or the kidney function test is normal, and you might need to do it a second time, maybe 2 or 3 weeks apart, to make sure that the renal function test is really normal before you use any contrast for anything. I mean, not only fibroids, but anything. You should look at the kidney function test, because ultimately the kidneys that will be excrete the contrast, isn't it? So the end-stage renal disease, for example, if you give gadolinium-based contrast to enhance MRI or magnetic resonance angiography scans, then you would need to be aware that the NSF or the NFD could be pathologies the patient could suffer from. And how would you know? Well, they could be red or dark patches on the skin, burning, hardening, tightening, swelling, yellow spots in the whites of the eyes, trouble moving, mostly stiff joints in the hip bones and ribs, muscle weakness. So it is a debilitating and sometimes fatal disease. And if you have not been careful in screening women who could have this kind of contrast and help you with diagnosis, you could get a legal suit or a complaint from patient relatives, and which is why it's important to mention the gadolinium-based contrast agents, which should be used with caution. So remember the figures we talked about, the sensitivity, specificity, and the accuracy of prediction with ultrasound. MRI has got higher on all counts. Its sensitivity of nearly 86 to 92%, 100% specificity, and accuracy of 97% compared to ultrasound. So obviously it is a better predictor of the condition than the ultrasound, but the high cost is the limitation, so you can't use it in everyday practice, and availability also in time and location. Patients might find it harder to travel to a center, especially if they are in rural or semi-rural locations. Again, patients with pacemakers and certain metallic foreign bodies, you are probably best not using MRI, and claustrophobia is a relative contraindication where the patient might express a fear of closed spaces, and you can't put them into a tunnel where the MRI is being done. Okay, so what's the role of CT, or computed tomography? Limited role, like we were talking earlier. Fibroids are usually indistinguishable from healthy myometrium unless they're calcified or necrotic. So yes, so CT is often not used. The first line would be ultrasound, second would be the MRI, third may be computed tomography, but by that time you're already suspecting that there might be a fibroid, maybe calcified or necrotic, in which case this is a useful modality to screen. So calcifications are more visible on CT scans than on X-rays because of superior contrast differentiation. And we know that, and your radiology colleagues will tell you that. They'll take you through the pictures if you want. Okay, so next we come to endoscopy, or how are we going to diagnose? And sometimes we stumble upon that as an incidental finding. If you're just doing a hysteroscopy for perimenopausal bleeding, for example, you might find fibroids, or if you're looking for subfertility and menstrual symptoms, you might find a fibroid. If you remember the PALM classification of the FIGO, then it's usually 0, 1, and 2 that you will see when you put a camera inside the uterine cavity. And then there is a hysterosonography or hysterosaline sonography, where you introduce a catheter into the uterine cavity and then use sterile saline to expand the uterine cavity and do what you call a saline infusion sonogram, and you can see. And sometimes you can combine this procedure with a hycosi to actually check the patency of the tubes. So obviously this is a workup as a part of a workup for fertility patients, and you're combining with the assessment of the uterine cavity and the fallopian tubes when you're doing saline infusion sonogram or a hysterosonography. So the method is very simple. We introduce a radiopaque dye to highlight the uterine cavity and fallopian tubes on X-rays. And then submucosal fibroids at times are subject to incidental findings. You can see it just on the investigation. So laparoscopy and endoscopy, actually, by this time, you've almost always diagnosed it. Before the laparoscopy, you don't use laparoscopy to diagnose fibroids, but you're actually doing laparoscopy mostly combined with surgical measures. So, but laparoscopy is a tool, and sometimes you might stumble on fibroid uterus if you're doing a laparoscopy for other reasons, for example. Okay, so what are the differential diagnoses? It's important to exclude pregnancy, hematometra, adenomyosis. We've spoken about that. Uterine abnormalities, where you can have a large uterus, biconic uterus, for example. Ovarian cysts and tumors can sometimes masquerade. And then ectopic pregnancy in pelvic kidney and chronic inversion, of course. But the commoner things, commonly pregnancy, hematometra, and adenomyosis are the most common ones. So if you exclude pregnancy, hematometra, and adenomyosis, besides uterine abnormalities, account for most of the differential diagnosis. So how should I manage fibroids? So we've got a National Institute of Clinical Excellence here in the United Kingdom, 2018 guidelines. It says if imaging shows the presence of uterine fibroids, you should plan appropriate treatment with the woman based on the size, number, and location of the fibroids and her symptoms. So that's pretty comprehensive. So you take into account her symptoms first. Obviously, if it's a fertility sparing procedure or not that you're going to contemplate with her, and the site number and location of the fibroids that are the problem. Obviously, the specialist is going to have a look at the symptom profile, like dyspareunia, pelvic pain, discomfort, constipation, urinary symptoms, fertility, or obstetric problems like recurrent miscarriage, for example, from submucous fibroids, might need surgical resection of the submucous fibroids before a substantial pregnancy can result. So that is the approach that you would take with a clinical radiological suspicion of malignancy. You might want to actually do that. And then fibroids which are palpable abdominally or intracavity fibroids whose uterine length measured in ultrasound hysteroscopy greater than 12 centimeters. So you have to have a specialist at least looking at these women. So for people who are asymptomatic, the majority of women do not require any further investigation. Sometimes you might actually find fibroids in perimenopausal women. They've had the fibroids all their life, they are asymptomatic, and they've probably been stumbled upon because you're doing an investigation to check out the endometrial thickness while she's on HRT to exclude precancer of the endometrial lining. And then you just find out that she's got fibroids. So there's nothing to be done apart from arrange annual follow-ups to monitor the size and growth of these fibroids to exclude rapid growth or reason to suspect pelvic malignancy. So pharmaceutical treatments, I'm going to medical treatment now because that's the final part of my talk. So you usually do that fibroids less than 3 centimeters, causing no distortion of the uterine cavity. And when investigations, definite treatments are being organized, and if no improvement within 3 menstrual cycles, then you stop. Tranexamic acid is the first line of treatment. It is fertility sparing, so it does not cause any upset to the hormone cycle. You can use 1 gram 3 times a day for 4 days. Contraindications, as we all know, is thromboembolic disease, renal failure, and hypersensitivity. Do not use them with oral contraceptives because there's a risk of thrombotic events. So first line is non-hormonal tranexamic acid. Next, again, non-hormonal NSAID'S. You can use ibuprofen, and it reduces blood loss by 20 to 40%, and especially in those with excessive bleeding by inhibiting prostaglandin synthesis and decreasing menstrual blood loss. You can combine ibuprofen with mefenamic acid in the dose that I've written here. And the added advantage is obviously providing relief from dysmenorrhea. So you help with the pain and the bleeding, and also help the woman to continue to try conceiving, or if she's going through an IVF cycle, then she can use both of these modalities of treatment. The third is moving on to the hormone treatment. That's the long-acting IUS, intrauterine systems, usually used for non-submucosal fibroids, less than 12 weeks, 94% decrease in blood loss over 3 months, but you must at least persist for 6 cycles to see the benefits. Some women might get frustrated of not seeing results within 3 months or so because of irregular heavy bleeding. I usually give the example of contact lenses, for example. They tend to irritate the eyes for the first few days, weeks sometimes, before the woman gets adjusted to the contact lenses. And similarly for the Mirena coil, there has to be some time before you actually say this treatment has not worked. So the combined oral contraceptive pill, I just mentioned that it's ineffective. It does not seem to help the growth of the uterine fibroid tumors, but there aren't very many research papers that actually have looked into this in greater detail. So what about GnRH analogs? So these are temporizing measures in perimenopausal women. You can use it preoperatively to actually try and shrink the volume and the size of fibroids, and it's directly proportional to the percentage of cells that are estrogen receptor positive. And the dose in aleuprolide acetate, as you know, or Zoladex, as we call it here, is 3.75 milligrams. So you can use the longer acting one over 3 months, 11.25 milligrams depot suspension. The aleuprolide is once a month. The Prostap is once in 3 months, and then you've got add-back therapy if recommended, but not to be used more than 6 months because of fear of bone loss, as we all know. So then you've got the selective estrogen receptor modulators, or SERMs, and it's a molecule that blocks estrogen activity and has got a potential effect on fibroids. As you remember, the uterus has got both estrogen progesterone receptors in excess of normal, and also the responsiveness is higher, which is why the SRMs might work. Tamoxifen and raloxifene have been looked at. Tamoxifen has not been used because of hyperplastic effect on the endometrium. Raloxifene seems to work in postmenopausal women. And then you've got the progesterone receptor modulators, or SPRMs, and they work in 2 ways. They inhibit growth by downregulating insulin-like growth factor, and they also downregulate tumor necrosis growth factor, or TNF alpha expression. So the dose is mifepristone or aleuprolol acetate, and 5 to 10 milligrams per day. And mifepristone you can use for a year, aleuprolol acetate for about 13 weeks, and longer lasting PRM-associated endometrial changes can be seen in cystic glandular dilatation. So SPRMs are probably more studied and used than SRMs compared to, for example, GnRH analogs. So these are the ones, hormones you're talking about from the LNG. Well, the LNG we talked about. COC is not too much, but apart from GnRH analogs, which has been the gold standard of treatment, of the two, the SERMs and the SPRMs probably have more of a role than the SRMs. Okay, so in the UK, there was a warning from the medical regulatory agency in March 2020 saying the aleuprolol acetate license was suspended in Europe also because of risk of serious liver injury. So we have been doing liver function tests, and the advice was to contact patients currently taking ESMIA, and that's how we call it in the UK, for uterine fibroids, and the license was suspended to protect public health. I'm not sure what the state of that is in India. We can have that during the discussion. So the aromatase inhibitors, what about the role of aromatase inhibitors? So you've got 2 drugs, letrozole and anastrozole. Bone loss with prolonged use. I think that is one worry, but similar to GnRH analogs as well. And so there have been head-to-head trials with aromatase inhibitors versus GnRH analogs. And the benefit, if you say that, of aromatase inhibitors is in avoidance of flare-ups. So the rapid onset of action and avoidance of flare-ups probably goes in favor of letrozole. So a trial of letrozole could be undertaken prior to considering operative treatment. So there are other hormone treatments like lanreotide, insulin growth factor receptors, and the gestrinone, anti-estrogen receptors, and anti-progesterone receptors. And in long-term use, obviously, because they have got these anti-progesteronic activity, they can cause mild androgenicity, with acne, hirsutism, voice hoarseness, and seborrhea. But if you keep the treatment for a short duration, especially in perimenopausal women, or in, if you're pre-treatment or surgical treatment, then there might be a limited role. Vitamin D, there's probably some role in that, and EGCG, which is green tea extract, might also help in ways we still don't understand. So indications for non-medical intervention are infertility, recurrent pregnancy loss, asymptomatic pressure symptoms, rapidly growing fibroid, and symptomatic AUB or abnormal uterine bleeding. So you would want to do non-medical intervention or fertility sparing approaches. So you want to use fertility sparing approaches, not surgery, unless it's myomectomy, of course. So in conclusion, I would like to say that the fibroid workup actually requires a lot of detail, most of it history taking, clinical examination, imaging, and the differential diagnosis, besides approaching the drugs that can be used variously. And obviously there are different groups of people who will be suitable for different groups of drugs, and much will depend on site, size, location of fibroids, as well as the timeline of the fibroid presentation. So whether it's perimenopausal, or it's in the reproductive life, or in teenage years. So you will have different treatment modalities, a combination of both medicine and surgery, or surgery alone, depending on the symptom profile, and also what the woman wants, because obviously we keep our patients in the center of decision-making, and she should be involved in her decision-making as much as her understanding allows. Thank you so much for your attention.
Thank you so much, sir, for such a crystal clear lecture. You have covered everything. Ulipristal is banned here also. We are not using now, no more ulipristal. Only the one preparation of ulipristal 30 mg, 120 mg as an emergency contraceptive we are using.
Yes.
But for this, it is not, we are not, here it is also banned.
Yeah.
Sir, I have received some questions. With your permission, can I take that questions?
Yeah, sure.
Yeah. Program has gone live on the YouTube also, so some questions I have received there.
Okay.
Yeah. This is from Dr. Gupta. She has joined all the way from Lucknow. She is writing the question. Open the two pages. Just a second. Yeah. Yeah. The question is, how much is the prevalence of intrauterine adhesions after the myomectomy?
Okay, so I think there's no straight answer to the question. Much will depend on the grade of the fibroids, if it is 0, 1, or 2. So how much resection you're doing, the surface area of the endometrium that is involved. But if you ask me, in my clinical experience, I haven't seen intrauterine adhesions unless you are removing several fibroids and a large part of the endometrium has been stripped. If you look at some studies, they say at least 60 to 70% of the endometrium has to be stripped before you actually talk about Asherman syndrome and uterine synecdoche. But less than that usually happens when you're dealing with submucous fibroids. But again, the number, size, positions, if it's near to the cornu, and the completeness of the resection also determines. And it's probably safe to leave some part of the fibroid intact, even if it is, so for example, if it is a grade 3, I'd probably leave a little bit just for the sake of the endometrial preservation than complete fibroid resection.
Right. Thank you so much. There's another question from Dr. Jadhav. He has joined from Mumbai. The question is, how much uterine artery embolization is beneficial for the treatment of symptomatic fibroids? Yeah.
So uterine artery embolization is very much being used nowadays. So it is one of the steps that is just short of surgery, and it is done as a day case procedure. And there are a lot of finance cost savings by not actually going through surgery, and especially in women who want to conserve their fertility, especially in women who want to save themselves a hysterectomy and they're about to go through the menopause, I think uterine artery embolization has a huge role to play. It depends on resources, of course, on the health economy, on how much funding is being made in the public sector. For example, here, uterine artery embolization for a patient is free because the patient doesn't have to pay for it. Whereas uterine artery embolization might have to pay for, you have to pay for in countries like the USA, partly because the insurers will pay it, and also almost completely in India, maybe the insurers will pay part of it, but sometimes the insurers don't want to pay for pre-existing conditions. So the health economy also dictates how much you're going to use the uterine artery embolization as a way of treatment.
Right, very true. Thank you. Thank you so much, sir. Sir, there is another question. This is by name, I'm not able to read. Yeah. This is by Dr. Singh. He is joined from Delhi. He's writing, as you mentioned regarding the use of vitamin D, he's writing, is there any effect of vitamin D on the recurrence of the uterine fibroids? Is it?
Okay, so yeah, vitamin D, I think the link is casual. I mean, if you look at it, they are saying, if you remember the infograph that I shared earlier, where it says vitamin D might help in the prevention of development of fibroids. But adding vitamin D probably does not help in recurrence of fibroids once you have done resection or once you have excised fibroids by myomectomy. It is probably just a health supplement like green tea extract. You can use it, but on its own is probably a limited mileage that you can get from vitamin D alone.
Thank you so much, sir. Sir, there is one question from Dr. Patil. He has joined from Satara. The place is near to Pune. The question is, could aspirin treatment modify the assessment of uterine arteries?
In what way? I mean, would you want to use aspirin to...
The question is, Dr. Patil, I request you please write the full question. There is one more question. This is, actually I have to change the page for the YouTube. That's why it's taking some time.
Okay.
Yeah. This is from Dr. Prasad. He joined from Chennai. The question is there any effect of intrauterine infusion of platelet-rich plasma in the treatment of uterine fibroid?
Not that I have heard, but I'd be interested in knowing how much it is used. It's definitely not used in the UK.
I have also not heard any time that for the treatment of fibroid.
But I'd be interested if there are any published research work or something. I'd be interested.
Dr. Nirmala, you want to ask any question? Chitra, one doctor has raised the hand.
Yes, please carry on.
Yeah, whatever the questions I received, I finished all the questions. Yeah. Dr. Nirmala, is it any question?
Yeah, can you hear me, please?
Yes, Dr. Nirmala.
Yeah, see, I want to know letrozole for how long we should use.
Okay, so letrozole, in our experience, we have used it for a period not exceeding 10 to 12 weeks.
Okay. And how are the results, doctor?
Results are pretty good, especially we have used it for pre-treatment evaluation, and the results are fairly good in trying to,
And do we need to give any add-back along with that?
No, that is the advantage. There is no need for add-back compared to GnRH analogues. This is something that doesn't need add-back.
Okay, thank you so much. Thank you.
Thank you.
Sir, these days some studies have come regarding the use of this letrozole and addition of the vitamin D, as you have already covered. So some brands have come in the India also. So they are also promoting. So you have used in some patients and you are getting good results?
We have good results. We haven't used the combination with vitamin D. I suspect that can be used. But letrozole on its own seems to have a very desirable result, which is probably at par, if not sometimes better than GnRH analogs.
Okay.
With
And
regard
sir,
to side effects, yes.
yeah. And sir, the dose you use the same dose for the every patient, or it changes according to the number and the grading of the fibroids for the
Yeah.
letrozole?
So we use that standard dose that I have used is for usually with BMI less than 30. If you've got a BMI of more than 30, between 30 and 45, we'd probably go up by 50% on the dose.
Okay. Okay. Thank you. Thank you so much, sir. I know your schedule is very busy, even though you have taken up time.
It's a pleasure. It's a pleasure to talk.
Sir, now I'm going to ask you some non-academic questions. As this show name is the Icons in Conversation with Dr. Ritu. So, sir, tell me what motivated you to become a gynecologist? Okay. First a doctor and then gynecologist. Is it your dream to become a doctor?
Well, my grandfather was a doctor in the British medical forces. And he was my inspiration to actually study medicine. So he practiced in pre-independent India. So there was nobody in my mom's generation to study medicine. So I was inspired to take it up from him. And as far as gynecology is concerned, I have a huge respect for women. And I think what a woman does for her family, the society, the community, the nation, and the world at large is something that men have really to measure up with. So that huge respect for women actually led me to study obstetrics and gynecology as a way of paying forward, because I haven't been able to look after my mother. So I think I should look after other mothers and other sisters and other daughters and somehow help. So yes, that has been my inspiration.
Great, great. So share some of your hidden talents with us. We all know you are a great academician. You are doing very good. Such a great teacher. So some hidden talents, what we all not know, please share that with us.
Yes, well, I have had very close links with the RCOG here, and I worked in the Royal College. I have worked also very closely with FOGSI and the FOGSI leadership, including Dr. Pai, Rishikesh and Rishma. They're both very good personal friends of mine as well. And recently I had traveled to India to actually participate in the AICOG, which are now being postponed to April, isn't it? So yes, academics has been my love throughout, and I love teaching. I am in charge of teaching of a large group of medical students. So that has been my my love and passion throughout. Apart from that, photography is one of my interests. I have an album of pictures I've taken, not of places, but of people, okay, of people, with their consent, of course. And yes, so that is my, because pictures speak a lot of languages in a lot of words. And I think pictures are very powerful in motivating people. And I'm sure a lot of you use pictures or infographics in your clinics and operating rooms to actually, help stimulate your staff into intellectual thinking and patients into intellectual thinking. So pictures are a very powerful way of emoting. And that's why in India, pictures carry such relevance. You have picture hoardings all over the place. You have pictures as in movies, and a lot of news channels and television programs actually depend on moving images to actually leave lasting impressions. So I think in medicine also, there is a huge interplay of pictures. And sometimes I would use videos in my clinic consultation to actually show uterine artery embolization in progress or endometrial ablation in progress, because patients understand that better. A picture message tells them much better than your explanation. So I somehow marry that up with my profession in a way. And actually I went into medicine, but my first love was English. I wanted to study English literature because I was good in English. But my dad said that you're not going to earn much as an English professor, right? So then I said, okay, then I should go into medicine. At that time, when I was growing up, it could either be a doctor or an engineer. So my maths wasn't very good. So medicine was the obvious choice. And obviously my grandfather was the inspiration, of course.
Thank you. Thank you so much, sir. So last question. Some tips for the upcoming doctors?
Yeah. I think before being a doctor, you got to be a good human being. You have to be empathic. You have to understand what the person is going through. Like they say, you cannot pass a comment on somebody unless you have walked a mile in their shoes. So you need to place yourself in their position to understand that a mother has probably asked somebody to pick their child up from school while she's making a visit to your clinic. So you might actually forget what you have said, and you have spoken to several patients during the day, but she will remember what you have said and even narrate it to her children and grandchildren. If you have said something memorable, she will remember it and carry it for many, many days. And I think that is why what you speak, how you speak, is so important, because people often don't remember what you said and how you said it, but they will always remember how you made them feel. So not only in medicine, but in your daily encounters with people, your friends, relatives, even passengers on a train, if you just be kind and be memorable in the way you come across, I think you do a great service to the community around you. That's my advice to the younger doctors of today.
Great. Thank you. Thank you. Thank you so much, sir. Thank you
so
once
much.
again
Thank you,
for
Dr.
sharing.
for having me.
Yeah.
Very kind of you to have me today.
It's my pleasure and honor, sir, to have you with us. So thank you, friends. And thank you, sir, once again. Thank you, Shield Pharma, for providing the platform. A special thanks to Dr. Nishant and Chitra. So friends, we will wind up today. And please stay tuned on the next Thursday. Today we have done on the Wednesday, but as all of you are aware, my shows are every time on the Thursday. So next Thursday, 8 p.m., we are having Dr. Rubina Sohail all the way from the Pakistan with us. On the 10th March, we are having Dr. Nandita Palshetkar with us. Stay tuned for the more upcoming details. Till then, bye-bye.
Thank you. Bye-bye. Bye again, Dr.
Bye.
Bye.
Bye.